Hello, my name is Simon Mason. I'm the new president of NESTcc. I say new because in fact I'm on my third week with the team, but I'm very excited to join NEST as part of MDIC and especially excited to present today this UDI Adoption to Support webinar. Thank you for attending today. We'll provide more details at the end on how you can watch this offline. First slide, please. For those of you who don't know, NEST is focused on transforming the way medical device technologies are tested, approved, and monitored, ultimately providing patients with better care. NEST is funded through a grant from the FDA, which is primarily funded by fees coming from ADUFA 5 and other sources. Next slide, please. Our focus is on leveraging our unique and neutral position to connect the right data sources to provide industry with real-world evidence that supports quicker and more efficient approvals. That includes curating the right data sources and research expertise to meet the specific objectives, catalyzing transparent, traceable real-world data across the process, and creating a central scalable system architecture. Next slide, please. We spend our time in two core areas, in evidence generation and supporting the collaborative community. We use our unique position to coordinate the activities of multiple players to improve the medical device approval process. But for now, we're going to focus on UDI, and I'm going to hand over to my colleague, Joe Ross, who is about to take over. Go ahead, Joe.
Lest anyone worry, I'm not taking over NEST. My name is Joe Ross, and I'm a professor of medicine and public health at Yale. And I co-lead efforts on behalf of the Yale New Haven Health System as a collaborating center as part of NEST. And it's my delight to welcome you all to this webinar today, where we're going to talk about UDI adoption to support RWE generation. You can see on the right of the slide the events for the day. We have a 2-hour webinar scheduled. We're going to start the day with the FDA perspective on NEST and the UDI. And at this session and in all sessions, the speakers will introduce themselves at the beginning of the session. We'll then move to a project update where Drs. Natalia Wilson and Sanket Dhruva, who I've worked with over the past many years, but on the past year and a half on this playbook, are going to present the amazing work that they've done developing this health system adoption playbook for how to for the UDI. We're then going to have a discussion of the health system from the health system perspective on the challenges and the reasons why implementation of the UDI is an important step forward. And then we'll have more of a group discussion among the panelists on actionable next steps to realize unique device identification. Next slide. I'll just note that we're going to be using a Q&A format with opportunity towards the end and within the panel in particular to ask questions. So please submit all questions in the Q&A box below as part of the webinar. I'll be screening it as will others of our panelists, and so we won't be answering questions at the end of each individual session, but we will towards the end of the panel discussion and then at the wrap up. And then I just want to call your attention about how to access the NEST UDI Playbook. You can see this link on the page, so you can follow along when the Playbook team is presenting it. There's now going to be a link in the chat so you can find it, and it's also available on the NEST website. So thank you again for joining us today, and I'm going to hand it over to Daniel Caños. Daniel?
Great. Thank you, Joe. My name is Daniel Caños. I'm the director of the Office of Clinical Evidence and Analysis within the Office of Product Evaluation and Quality in the Center for Devices and Radiological Health. Our office provides support to the device-specific offices that review and make decisions on approvability of submissions for medical devices, and we help in generating that evidence and helping building the ecosystem and working on the analysis of that subsequent clinical evidence. Our office also is the one that directly connects with NEST Coordinating Center on that cooperative agreement or grant. So we are working in a very hands-on way and collaborative fashion with Simon and his team. Very excited for Simon to be joining and be the president of NESTcc Coordinating Center. Next slide, please. So just to kind of bring it back to the collaborative community and a bit of a reminder of what it is and why we're here. So it's a continuing forum for private and public sector members, including the FDA, where we can work together on medical device challenges, achieve common objectives and outcomes, convened by the interested stakeholders, and may exist indefinitely, producing deliverables as needed and tackling challenges with broad impacts. Collaborative communities typically include diverse, relevant organizations and individuals impacted by a specific topic. For example, patients and care partners, academics, healthcare professionals, payers, federal and state agencies, regulatory bodies, industry, are all part of collaborative communities. Next slide. And that's exactly what we have convened here within the NESTcc Collaborative Community, really, tackling the challenges there, inclusive in the circle, really innovating as Simon led off in his remarks, how we really leverage real world evidence for regulatory decision-making, payer decision-making, and informing professional societies, patient groups, really the entire ecosystem as far as the total product life cycle performance of medical products. Next slide, please. As an established collaborative community, there's the NESTcc Collaborative Community governance. We have the convener and this mechanism, such as today, for sustained engagement. We also have the diverse representation of which I spoke, and all meeting the criteria for our center's participation in this community. CDRH evaluates the public health impact of the communities, its alignment with our regulatory mission, and current priorities and resources as part of our periodic assessment. There are several resources, including performance metrics and outcomes defined by the collaborative communities, and that help to conduct these evaluations. CDRH also routinely looks at the collaborative communities for whether they are the most effective approach compared to other alternative approaches. Next slide, please. And so the NESTcc Collaborative Community objectives, as stated, are to coalesce diverse medical device stakeholders around the initiatives that further the utilization and beneficial impact of RWE, to find common paths forward on tough and broad questions, and present leadership and consensus-driven guidance to the community, providing a forum for stakeholders to work proactively to speed innovation and enhance safety and effectiveness of medical devices and health technology. Next slide, please. And so my role as the CDRH liaison is to gather input from relevant CDRH sources prior to the meeting and communicate publicly, if you could back up one slide there, available information to the collaborative community that is pertinent. I also bring experts such as my colleague that'll be following me to the table for topics such as UDI to bring those expertise from the center and to the table in these conversations. And I participate on behalf of the center, representing the regulatory perspective during meetings, actively participation, not just kind of a listening mode aspect. And so you'll be hearing a lot of the FDA perspective in the next section here. From there, on the collaborative communities, I share back relevant information with the CDRH senior leadership team and the executive sponsor, who is Dr. Jeff Shuren, after each of these meetings. Next slide, please. So really excited with where we are today. FDA first recognized NESTcc and participated in the collaborative community in 2019-2020 with the web launch. Then we had the kickoff webinar for UDI adoption and application in the fall of 2020. Public comments were sought in spring of 2021, which was followed by our think tank in fall of 2021, where we talked about the short and long-term goals, and for device identification, which were informed by the preliminary study findings. And today, really excited to be joining you all for the release of the UDI implementation playbook. Next slide, please. RWE data sources are the foundation of the NEST system, in part as a response to lessons learned from the test cases and to enable NEST Coordinating Center to generate more actionable real-world evidence. NEST is evolving from its original structure to include third parties to serve key functions of the system. Connector or aggregators will bring together data from third parties, including the network collaborators, as well as some commercially available data sources. Moving towards a common data model approach to put all data on a kind of common platform for analysis. Where aggregated data can be analyzed on that analytic platform and resulting analysis provided to customers to generate real-world evidence to support their needs. Next slide, please. Bringing together data on a common platform entails that common data model approach, aggregation mechanisms, including privacy-preserving approaches, data quality assurance, and easy and consistent identification of medical device use. Next slide, please. More widespread implementation of UDI will enhance analysis of devices on the market by providing a standard and clear way to document device use in electronic health records, clinical information systems, administrative claims data sources, registries, and the like. This will provide a more robust system that can be leveraged to support pre-market approval or clearance of new devices and the use of currently marketed devices. So really exciting period here with the rollout, with this rollout. And to talk a little bit more about the FDA perspective for the FDA UDI program, the current state of UDI, and a look ahead is Indira Kunduri, who is the Deputy Director of Division of Surveillance Support within the Office of Regulatory Programs and Office of Product Evaluation and Quality.
Thank you, Daniel. Next slide, please. Good afternoon, everyone, or good morning, wherever you might be. My name is Indira, and I am delighted to be here today to talk to you all about the UDI program and give you an update on where we are. Next slide, please. So we'll talk about program status, share with you some current activities we are engaged in, and also look ahead to sort of what we think is coming in front of us. Next slide. So as Daniel mentioned, device identification is incredibly important for effective, RWD utilization. So as part of real world data, we're very glad to be working on the UDI program, glad to have a huge lead in here. The UDI rule was published in September 24th of 2013. So 9 years in, almost 10 years for this September. And the intent, of course, was to have a system, a standardized system to identify devices to make sure we can adequately identify them throughout the supply chain, all the way to patient use and documentation, enabling documentation during patient use. And the UDI rule requires that all device labels and packages contain the UDI, and then key device identification data be submitted to the Global Unique Device Identification Database. Next slide. So really quickly, what is a UDI? UDI is a standardized identifier, and it gets you away from the proprietary identifiers that have been in use, and we're looking that it is slowly fading away, and people are moving to utilizing UDI for all their needs, both supply chain and clinical needs. So having a standardized identifier essentially removes the context-based identification, eliminates it just provides you a standardized way, unambiguous identifier throughout the supply chain. And because the rule requires that the UDI be available both in human readable format. So as you see the numbers on this slide here under the barcode, if you can see my mouse moving, and also in the ability in a scannable format, automatic identification and data capture. So upon the patient bedside, you are able to scan this barcode and capture key UDI UDI information. The UDI is composed of a device identifier, which identifies a model and a version of a device, and also the manufacturer or the labeler of the device, and production identifiers, information such as the lot number, expiration date, manufacturing date, things that would be incredibly useful during a recall. The device identifier is what would help us incredibly in the public health space, allowing us to aggregate device events accurately for a version or a model. So you can tell as the device evolves over time how the device has performed. As updates were made to the device, were they really effective? Did they render the device more safe, or were they problematic? And that's the power of what UDI enables us to do. Next slide, please. And with the UDI program, we are really at a very exciting space. We've hit a key milestone as of last December. As you see on the slide, the UDI requirements went into play based on device risk class. So class 3, the highest risk devices were required to comply with UDI rule requirements back in September 2014. And we did provide some additional time for certain requirements. And now we're happy to say, as of December 2022, all devices that are required to meet the UDI rule requirements should be in compliance. So moving forward, all those devices would have UDI on the label and data submitted to the Global Unique Device Identification Database, which now has close to 4 million records. So it's really a key milestone. The infrastructure, if you will, of having that standardized identifier be present is now in place. Next slide. So what is next for the UDI program? Next slide, please. It's really UDI adoption and implementation. And as Daniel mentioned, it's really for us, the promise of real world data and real world evidence and what that brings to us in terms of patient safety. Next slide. So from that regard, from a UDI implementation perspective, within CDRH, we're really excited to be able to utilize UDI for device total product lifecycle review. So if you start at the top at 12 o'clock, as devices come into FDA for pre-market approval, once the device is approved or authorized for use, we start prior to commercial distribution, devices are required now to register on list and also submit data to the GoodID database and have UDI on the label. And then as post-market requirements come, we get annual reports from companies, and we have certain mandated post-market studies. We are getting UDI data as part of those reports and studies. And then moving forward, as UDI expands into sort of the space of registries and electronic health records, and we'll talk about that just a little bit, you'll see UDI coming in as part of those data sources. And finally, when it comes to post-market safety, adverse event, MDRs and recalls, we're definitely seeing UDI data, and I'll talk about that in just a minute. And then we complete the full circle. By this time, as another device comes in and we get predicate devices to show us the safety and effectiveness of a particular device in front of us as we review it, we will have a rich source of data to draw upon, and utilizing UDI will really be able to assess the device performance to make better regulatory decisions. So that's really sort of the total product lifecycle approach we're looking forward to leveraging. Next slide, please. Where we have seen the most amount of information coming to us and able to leverage is really in the post-market adverse event space. So as you see from this graph, the UDI rule was published in 2013. We have seen a gradual increase in the number of adverse event reports coming into the center with UDI information populated. And this is incredibly powerful because we now really are able to pinpoint the exact device that was responsible for that adverse event. And we're now looking at almost 80% of our MDRs coming in with UDI data. And this is really helpful to us as we're able to assess how have the UDI rule requirements been implemented? Have the UDI rule requirements been implemented correctly? What are we learning about the evolution of the device as it goes from, version 1 to version 2 to version 3, because it's giving us that ability to aggregate device data more accurately and not having to depend upon text information or proprietary identifiers such as catalog numbers. Next slide, please. Another space we are looking, and we did quite a bit of work here, is to educate the importance of including UDI information as part of recalls data that comes into the center. And as you see here, just over the past fiscal year, we've seen a huge increase in the number of recall submissions coming in with UDI information. What we heard from stakeholders was that there was a great need for inclusion of UDI here, and this enables them to identify the recall device more quickly and pull it off of shelf and away from patient use. And we're also looking at these UDIs and looking at the UDI information coming into us in the form of adverse events, really trying to find new insights, if you will, into device performance out there in the real world. Next slide. So moving beyond just CDRH, if you go sort of beyond CDRH to the larger healthcare ecosystem, what's really happening if you start at the 12 o'clock again, once there is FDA device review and approval, the green line from there to the manufacturer going into commercial distribution, that's pretty much complete, as I mentioned, based on the infrastructure. We have UDI on the label, data in the Access Good ID database, data in Good ID database, and now manufacturers put the device into commercial distribution. We are now seeing, as you will hear later in this webinar, there is definitely an uptick in hospitals implementing UDI. So we are seeing hospital systems being able to utilize UDI for inventory management, electronic health records capture, and of course, recalls, as I mentioned. And then if you move from the 6 o'clock up to 9 o'clock, you see there is good amount of movement happening here also, where there are incentives, and we'll talk a little bit more about this. There are things getting in place, if you will, to enable larger capture of UDI as part of device claims transactions, registries, and really leading to that rich infrastructure building for real world data capture. And that's happening too, and I'll talk about that in just a minute. Again, coming full circle back to FDA, providing us that capability to really understand device performance, so we are making the right decisions on behalf of patients and public health. Next slide. So just want to share with you some of the work that's going on in the HHS in some of our sister agencies. The first one, of course, is the Center for Medicaid and Medicaid Services. The big news here, and I was hoping that we would get some information to share with you today, is really inclusion of UDI in claims transactions, electronic claims transactions. X12 is the standard that is used for exchange of electronic claims information. The recent update to the X12 standard includes ability to capture UDI-DI. The National Committee on Vital and Health Statistics held a public hearing January 18th and 19th to get public comments on adoption of this standard, and we're actually waiting for them to make a recommendation to CMS, which is due, in fact, anytime, hopefully sometime soon this month. And that will be a huge step if that goes forward for inclusion of UDI in claims, again, providing really that incentive and that large, rich data source and infrastructure building for our RWD generation. Additionally, pharmacy reimbursement, there is a standard that's used for exchange of pharmacy reimbursement information called the NCPDP standard. This has recently been updated also to include UDI-DI, and there is actually a proposed rule that's been put out for adoption of this standard. So that's moving forward as well. And lastly, interoperability standards all include UDI also. The United States core data for interoperability also includes UDI, and because of the health IT certification criteria to include UDI, so in order to be certified, electronic health vendors needed to have UDI capture capability. Because of that requirement, we now have close to 350 electronic health record systems have UDI capture capability. So really you see that infrastructure building sort of expanding and hopefully moving us in the right direction. Next slide. Globally as well, lots of movement in the UDI space. All the countries you see in dark blue currently have a UDI regulation in place and are receiving data similar to the data that we are capturing in the GUDID, Global Unique Device Identification Database. Now the companies in light blue are contemplating or working on developing UDI regulation. And the need of the hour in this space is really harmonization of UDI requirements globally. So if you're talking about a device that's being made here, but perhaps being distributed elsewhere, one UDI, you should be able to identify. Or if you get medical care here, and then you get medical care while you're traveling in Europe, there is some level of harmonization and ability to identify the correct device that's being used. Next slide. So in addition to the work we're doing in post-market space with adverse events and recalls, we are also doing multiple things to really continue to support adoption of UDI. A key part of that is UDI compliance. And as I mentioned, this is the 10th year since the rule has been out. So to date, FDA has had a soft touch, if you will, for UDI compliance, right? Our focus has been, let's help you understand the requirements, let's help you implement the UDI requirements. Now we're actually going to look and see how is the compliance with requirements, right? Are the requirements being implemented correctly? A lot of this is being coming out as we are looking at the data and utilizing the data. We're also looking to see those who might be completely out of compliance or partially compliant. So we want to make sure there is properly formed UDI on device labels and packages so that when there is a scan happening at the bedside, it is able to capture the data correctly. We're looking at the completeness and quality of data submission in GUDID as we're beginning to use it, and also what type of UDI data is being submitted as part of those MDRs and recalls and how usable are they. UDI information will be part of routine inspections, and we'll also be looking at devices coming from outside the US into the US as part of imports label screening. So these are all some compliance activities we are undertaking to really make sure that we are supporting the larger healthcare-wide adoption of UDI. Next slide. Now, in addition to that, as I mentioned, we have close to 4 million records in GUDID. We are looking to see what can we do to make sure the data is available in a format that's easy for people to use for adoption. So looking at development of tools on the public portals for GUDID. And one thing that we're doing, which is expected hopefully by October of this year, is releasing the global medical device nomenclature codes on all the GUDID public portals. GMDN codes allow you to categorize devices into different buckets, similar to the FDA product codes, which tend to be more regulatory in nature. So we're looking forward to releasing this. In addition, we're also updating the implant list API using the GMDN implant attribute. So what this will allow you to do, any healthcare provider or anyone looking to get a list of devices that are implants, it will be hopefully more granular and more specific than the list that we currently have out there. In addition, we are continuing to collaborate with stakeholders on UDI adoption and looking to further our UDI education efforts with hospitals, and very excited to be part of the UDI Collaborative Community here in NEST and support the release of the playbook, which is a huge step to move forward with adoption. Next slide. So that was just a quick summary. More to come through this webinar. I do believe that there is plenty of momentum built up for the UDI program. We are very excited to be at the spot now where we have completed the infrastructure and ready to move forward with the next activities in front of us. Exciting. So keep an ear out, if you will, for the announcement on UDI inclusion in claims. which coming soon. Fingers and toes crossed there. So thank you. And I will turn it over now to the next speaker, Sanket.
Great. Thanks so much, Simon, Joe, Daniel, and Indira. And it's my real pleasure to now share with all of you, along with my close colleague, Dr. Natalia Wilson at Arizona State University, the official release of our playbook, which we wrote together with Joe Ross and Laura Guimar, a playbook for health system unique device identifier implementation at the point of care. I'm an assistant professor of medicine at the University of California, San Francisco. Next slide, please. So I want to first, before getting into the playbook, acknowledge incredible support and guidance and expertise from the individuals listed here who comprised our playbook advisory group. We'll talk a little bit about the methods in a moment, but all of these individuals have been closely involved in UDI for the past many years, oftentimes for the past decade or even more, since the final rule, and provided a ton of expertise which helped to inform the playbook, which we'll share with you here. Next slide, please. So an outline for our approximately 25-minute presentation here. I'll be here for the first half and then pass it to Dr. Wilson for the second half. We'll talk a bit about an introduction to the NEST UDI project. We'll then talk about motivation for the UDI playbook. We'll then provide an introduction to the playbook and the different sections of the playbook so that you can understand what we've conveyed there. And then we'll wrap up with some next steps, which we'll discuss further later in the session here today. Next slide, please. So we've been engaged from those of us here in the session, Dr. Ross, Dr. Wilson, myself, along with colleagues, including Dr. Joe Drozda, Dr. Jennifer Ridgway, and Dr. Nilay Shah, on this UDI project since late 2020. And the first part of the work that we did was AIM-1, where we characterized UDI adoption, including barriers and facilitators among NEST Research Network Collaborator health systems, focusing on real-world evidence generation using electronic health record data. What we learned in this, I'll share in a moment. We then published these results, if you're interested, in BMJ CIT officially earlier this year. And essentially what we learned is that UDI has been adopted at some NEST Research Collaborator health systems, but it has not been adopted at others. And again, we'll share that in a moment. And then the work that we've been conducting since then is we've developed this UDI playbook with the goal of guiding NEST Research Network Collaborator systems, but really any health system to advance UDI adoption at the point of care in their health system, which can then enable the performance of studies to evaluate the safety and effectiveness of medical devices as used in routine clinical practice. We've also created a NEST, a UDI Center resource at the NEST website, and which you can see at the very bottom of the slide, the NESTcc UDI Center, as well as a brief resource. Next slide, please. So here's really the motivation for the playbook. As Indira shared, we have the FDA UDI system rule from September of 2013, so coming on about a decade. So we have regulation, and we've seen tremendous progress. As Indira mentioned, we met this major milestone last December, where the vast majority of medical devices now have UDIs. So, and we've seen it included more often in adverse event reports. We're seeing it more often included in recalls. We're seeing tremendous progress with the UDI system. However, there are lots of challenges. There's no requirement for health systems to implement UDIs. There's no process as a standard for the electronic capture of UDIs at the point of care and integration to electronic health records. And therefore, there's no broad availability of UDIs for use. And that's what we learned when we were interviewing and surveying health system members that were part of the NEST Research Network. Oftentimes they said, well, there's really not a requirement. And There are many competing priorities, particularly since the onset of the COVID-19 pandemic in 2020. And so integration of UDI into EHRs, UDI capture and implementation, unfortunately, oftentimes not a priority. Nearly always not a priority, actually, in the when with respect to all these competing priorities. And so we tried to address this through the UDI Playbook by trying to provide an aggregation of literature and compiling expertise about health system UDI implementation, bringing it all together, because although there have been disparate efforts at various places and there's expertise among individuals across all spectrums of healthcare as related to UDI, none of this information has really been aggregated and pulled together in a single place. To the next slide, please. So what we did is we aggregated literature on UDI implementation at the point of care and use, more than 65 references, all of which were published that we pulled together. As I mentioned, we created an advisory group to whom we're very grateful and who provided a lot of help. The development of the playbook, which again is now publicly available today, is we drafted an outline, which we shared with the advisory group. We then drafted various sections based on input to the outline. We then released the playbook late last year, where it was available for about 30 days for public comment. We received those public comments and integrated them as they fit. And then we submitted the playbook to NESTcc. And we've then worked on formatting and trying to make it as strong and as useful as possible. As I mentioned, the playbook was informed by reviews, input, and targeted feedback of advisory group members who have a lot of expertise, many of whom have published work that helped to inform the UDI playbook, that helped to inform the references which are available, as well as shared their own expertise. And again, the final formatted playbook is available today. You can see the link there. And again, we'll share that at the end of this presentation. Next slide, please. So here are the 11 sections to the playbook. And I'll cover the first few here and then pass on to Dr. Wilson. So we have an introduction. We discuss the benefits of the UDI, which includes a one-page summary of the benefits of the UDI that can be easily shared with health system leadership. We discussed defining steps for UDI implementation, implementation planning, and implementation development, the actual implementation process, plans for sustainability, as well as advancement, the use of UDI, which has a myriad of uses that can help to benefit the overall medical device ecosystem and patient care, a conclusion, aggregation of all of the resources and references that we could find, as well as appendices, which we will share with you in a screen share in a few minutes. Next slide, please. So the introduction to the UDI playbook discusses the goals of the UDI system. It discusses the legislative and policy motivations, including 2007 FDA and 2012 FDA Safety and Innovation Act. Discusses the basics of UDI for individuals who may not be completely familiar, including the DI and the PI components. And then we also discuss how necessary, how important it is to have the UDI available for rigorous real-world evidence generation, and the challenges of trying to generate rigorous real-world evidence about medical devices without the UDI. Which is just very difficult because medical devices simply oftentimes cannot be identified accurately and specifically without UDI as a key starting point. Next slide, please. We then discuss the myriad of benefits of the UDI. And as I mentioned, there's a one-pager that is downloadable and easily printable so that it can be shared with health system leadership, with stakeholders who at a given health system whose input will be necessary to get buy-in for implementation of UDI at the point of care. So the benefits that include improving and supporting clinical decision-making, improving clinical workflow, providing information to patients about medical devices, adverse event reporting, again, real-world evidence generation, And then very specifically at the health system, there are lots of benefits at the health system level: inventory management, managing recalls, procurement and contracting, as well as finance and revenue. To the next slide, please. We then pivot and discuss defining steps for UDI implementation. What does it actually take to implement UDI at a given health system at the point of care? It's important to create awareness of the UDI and its multiple benefits. It's important to delineate examples of the return on investment, as well as the clinical and the economic cases for adoption. It's important to identify and engage UDI champions, and it's important to obtain leadership buy-in. And I just want to stop there for a moment and just discuss the importance of all of these factors, which again, we discuss in depth and detail in the playbook, and just summarized here as these 4 bullet points. Is what we've learned is that at the health system level, UDI implementation at the point of care is not done nearly any time for real world evidence generation. It's done at the health system level because there's awareness, because there's motivation, because there's a sense of return on investment. There's a sense of benefits to the health system and the patients for whom who receive care within a given health system about what the UDI can bring. And so it's very important to be able to delineate these benefits, which must be then accrued at the health system level. And then almost as a side benefit, the UDI becomes available for real world evidence generation. But the primary motivation for the investments, the effort, the resources that must be committed to UDI implementation are not derived at the individual health system level from desire to create robust real world evidence for medical devices. But therefore, all of these steps are so important in order to get buy-in, to get the resources, to get the support to implement UDI. So then UDI can be available and can be used for RWE generation. To the next slide, please. Next slide, please. And so we have even put together an elevator speech for UDI, try to get buy-in very succinctly. The UDI, a unique code required on the label of a medical device, is the data to electronically identify the medical device. Use of UDIs in clinical care, recall management, supply chain management, finance and revenue, adverse event reporting and research elevates accuracy, efficiency, and most importantly, patient safety surrounding medical devices. Really trying to get attention to these, again, myriad of benefits and always keeping the patient at the center. To the next slide, please. And here we have, won't go through all of these details, but again, examples of return on investment, clinical and economic cases for adoption. As an example, a survey of hip and knee surgeons showed that oftentimes surgeons could not identify a recalled, a hip that needed to be replaced at the time of revision surgery. And there were consequences for patients: longer procedures, more complex procedures, more blood and bone loss, longer recovery times. With the UDI, this would not be an issue. The device that needed to be replaced would be easily identifiable, and patients would again gain many benefits. And on the right half of the slide, we have health system examples of return on investment, projected savings from UDI implementation, reductions in excess inventory at Mercy, at Duke University Health System. Dr. Chang will share with us again benefits in terms of how much effort was needed to support UDI implementation, benefits in terms of revenue recognition. And again, we have a couple of additional examples there. So really trying to delineate how there is a significant benefit, both clinically, but as well as economically, to help motivate UDI adoption. And for the remainder of our presentation of the playbook, I'm going to now pass to my colleague, Dr. Wilson.
Thank you, Sankat. Hopefully I'm up on the screen. First of all, I want to introduce myself. Excuse me, I'm Natalia Wilson. I am the Executive Director in the Center for Healthcare Delivery and Policy at Arizona State University. And I've been involved in research, particularly focused on health system implementation of UDI and the value and perceptions of that value from a clinical and patient standpoint. So I want to pick up this really kind of first key area of the playbook that is focused on those defining steps, or how you really build the case to get support and buy-in from leadership to move forward with UDI. And so really the third piece of this thing talked about the awareness that can be built, really delineating and sharing those return on investment and clinical and operational benefit that other systems have accrued. But really the third piece of this is identifying and engaging your UDI champion or UDI champions, particularly your clinical UDI champion. And so in the playbook, not only delineated some of the key areas champions come from, as you can see on this figure on the left, the clinical arena, supply chain, administrative, maybe a C-suite member, but also provide some examples. These are just a couple examples, for instance, and we don't give the names of the person, but the sort of title and role that they play. And at Mercy, from a clinical standpoint, this was a cardiologist and a researcher are very involved in UDI implementation, and then using their work with UDI and UDI to move forward for real world evidence generation and doing some of those early steps. From a supply chain perspective, their supply chain leadership was very involved. And from a C-suite perspective, their chief nursing officer. And at Duke, their clinical champion, still their clinical champion, is a clinically active interventional cardiologist and informatician. And they also had involvement of supply chain, their VP of supply chain, and their administrative leads of the point of care sites where they first implemented. Next slide, please. So, these are the key areas to build the case. And then to approach leadership, to identify leadership, which is laid out in the playbook, who's going to provide the resources. And what's been included is a high-level list of those 4 focus areas of how you put together a presentation for leadership. And there's actually included in the appendix leadership presentation template. And the outline you see is from that. So the first half is really populated, things that we all kind of continually put into presentations on UDI. What is UDI? An illustrative example of it. What's the purpose of UDI, from which you talk about patient safety and operational value and meeting regulations and for research, and then detailed benefit in each of these areas of UDI. And then in the second half, really provides the opportunity for organizations to plug in their own information. So what is their anticipated benefit and use for their system? And what are some of the problems they're seeing in some of the different areas, clinical or inventory management or recall management, and some of the costs associated with that? And putting forth a project plan, and what are those resources that are going to be needed, both from a funding standpoint, but also in-kind work. Next slide, please. So after building the case and getting approval, the next step of the playbook is really that planning for implementation, which is a critical piece that may take several months, 6 months or more, to do really effectively. And there's 4 key areas that have been laid out in the playbook, as you can see here. And I'm just going to touch on them just briefly. One is to establish the governance structure. So to really pull together those key people to represent supply chain, the clinical point of care, IT, and finance to come together to govern this initiative. The second area is to think through and engage those stakeholders that have the expertise to do this work. Generally from supply chain management, from the IT perspective, point of care clinically, often a project manager to oversee the initiative, but just really folks, and who are those folks at the hospital system that are going to have to come together to do the work. The third area is to perform initiative mapping. And this really includes identifying, and this is laid out in the playbook, but identifying that site you're going to start with, that point of care site. And a lot of times it's been the cath lab, honestly, in many health systems. But to really map out the device flow as it goes through various processes and IT systems as it gets to that point of care site, and do various flow maps. And to really think about this in 3 particular areas: from a data perspective, from a workflow perspective, and also those financial opportunities. And lastly, to really plan that education and training and support, and think about who are those groups that are going to be impacted, so need to be educated, which has been laid out. So in the playbook, so supply chain management with changes to systems and process and inventory management. Obviously, those at the point of care, in charge capture, and what is the support you're going to stand up? Who's going to do the education and in what format? Next slide, please. So after the planning, the next section of the playbook is the development, the actual really hard work, the implementation development. Not to say the planning's not hard work. There's a lot of hard work that goes into that section. And I'm going to talk about these in a little more detail. But the technical build is quite a heavy lift for organizations. And they're really evaluating and moving from kind of different processes and IT systems to an aligned system around UDI. From a relationship standpoint, this is really the glue, because UDI, as many of you know, implementation of UDI involves folks in different areas of the health system that are really in silos, sometimes don't necessarily work together traditionally, but they have to work together and coalesce around a common goal and bring their expertise to the table. Workflow assessment and re-engineering or redesign may actually involve formal business process modeling. And then your education begins. So next slide, please. So in terms of the technical build, this is a figure that's been included in the playbook that was designed to lay out those critical areas that you must think about as you're building your IT infrastructure. One is that database that's going to support UDI scanning at the point of care. The next is where UDI is going to be scanned and electronically captured before it's used in a patient. And then where the UDI will be captured at that point of clinical care. And then where you may want to transmit information, the UDI information, after the device has been used in a patient. And listed here are potential sites for these various aspects. And you'll notice there's not one answer here. There's lots of possibilities in this space, which is part of what adds complexity to building the IT infrastructure. Next slide, please. Also included in the technical build area, and this was something that was really important as we were thinking through the playbook, is to bring together examples that are in different publications into one space, as Sankat said earlier. And there are really quite detailed examples from 5 different health systems, not only where UDI has been implemented in their system, but also specifics of the IT systems that they've used, and what are the various tasks that are handled by the different IT systems, and also in some cases where they had to make a transition, potentially from a standalone system to something else that could support the UDI implementation. This is just one example of Geisinger that just gives you an idea of the type of information that's included. This is at a high level. There's a lot more detail in the playbook. Next slide, please. So moving after the technical build, and really a lot of these, kind of areas don't happen in isolation. They're obviously crossover areas as you do an implementation and the development of this. But as I mentioned, relationships and coming together collaborative work, whether it's informal work groups or ad hoc work groups, is absolutely the glue. And this really taps into those kind of areas of expertise that are needed for UDI implementation and highlights these groups that are critical to be part of this. Leadership obviously is really important at the genesis of this, and very important so that personal staff know that there's organizational buy-in for UDI implementation. Both supply chain management and the UDI champion basically interact with everybody. And supply chain often, interacts not just internally, but externally. So this figure really kind of, I think, encapsulates those key groups that need to come together, and also with all the arrows, really some of the complexity involved in this. Next slide, please. And then education and training. And as was done previously for leadership presentation, also included in the playbook is not only a high-level list of those key groups that need to be educated, like supply chain management, the clinicians at the point of care, those in charge capture, and also introduction to this to physicians, just to get the bottom line. This is going to be happening at your procedural site. But not only included in the text, but also included is an education presentation template that again includes the information that's pre-populated, and then the second half, the opportunity for an organization to be more specific and target this to who they may be educating. What is the purpose and benefits? How is this going to impact your workflow? And what training is going to happen, and how do you quickly access support? Next slide, please. So then really after the next section, after we've talked about the planning in the playbook, the development in the playbook, now it's really go live. And there's been most of the work and the training and the planning should happen obviously before this day. But the playbook includes some really important pointers to think about, one of which being to perform a complete year-end inventory, and that real and critical importance for on-site support, not just the day of implementation, but for many days or even weeks thereafter. Next slide, please. And the next section developed in the playbook is focused on sustainability and advancement. So once UDI has been implemented at a site, how do you really maintain the quality and integrity of it? And thinking through some of these issues that are presented, such as having existing staff train new staff at the clinical point of care. And also to monitor UDI capture and documentation through a dashboard to make sure you're not seeing a drop, so that you can then investigate where is this happening. And then there's, as health systems, again, think about moving to next sites, really not only learning from initial sites, but also really portraying those benefits that have been accrued at the original site. Next slide, please. And I want to just briefly touch, because I know we're running out of time here, included and elaborated upon in the playbook are examples of UDI, real-world data enriched with UDI that's been used in real-world evidence generation. And although this is a nascent area, there have been projects that have done this. There are publications that are referenced at the bottom of these slides about this. And a couple examples are the NESTcc supported thermocool projects, where UDIs were used to identify those specific medical devices used in the study, the cardiac ablation catheters. UDIs were used to link the device data to patient level data. And stemming out of this were safety studies conducted on a specific medical device when used in a specific clinical condition. Next slide, please. And another example stems out of the UDI demonstration project done at Mercy that was then operationalized in the BUILD initiative were expanded to Geisinger and Intermountain Health. And the bottom line is UDI-enriched research databases were created at all three of these sites based on a common data model, leading to a distributed data network from which comparative effectiveness study was conducted, comparing patients who had received 1 or 2 drug-eluting stents. And the outcomes were consistent with prior randomized clinical trials. Next slide, please. So I just want to wrap up as Sanket mentioned, the goal of this playbook was to provide a resource for certainly NESTcc network collaborators, health systems to support UDI implementation in their health systems so the data could be used in real world evidence studies, but really for any health system that's moving forward, so that next steps from this, so we can continue to build on this work, so we can realize those goals of the FDA rule and of NESTcc, and of course, use of real world data to generate real world evidence about medical devices. Next slide, please. So I want, if Sarah just has a moment to share her screen, I want to just make the audience aware of these 5 appendix items that are available that can be viewed. They're in the playbook. They can be downloaded. Sarah, I might have you just scroll down a little bit if you would, please. And first of all, a checklist for UDI implementation. This was a great recommendation out of our advisory group, so thank you. That really summarizes the text of the playbook, but into a real actionable list. And after this, we'll go to the next. There, as mentioned by Sanket, there's a 1-pager that can be downloaded that summarizes benefits. You could go to the next one, Sarah. And a 1-pager that summarizes examples about ROI, clinical and operational benefits. And lastly, the 2 slide deck. Obviously, this is in the slide deck format, but really shows you the detail that's included, pre-populated, and what organizations can fill in themselves to really augment their presentations and make it very specific for their organization. Go back to our presentation, and I will wrap this up. While she's navigating back, it's we learned a lot in the process of doing this. And next slide, please. Thank you. And really were some, when we think about needed next steps, there were some key areas that really rose to the top. One was certainly, and we've talked about it, that broad awareness and education about UDI and its benefits, but in a simple way. It can be really complex. We've given a lot of thought of how to broaden this so it becomes a little more mainstream. Number 2, the IT infrastructure and that need for, number 1, greater transparency for health systems of what supports their UDI implementation. There's tremendous diversity with the choice of point of care systems that are accepting the UDI. And for some of the issues of interoperability and some of the very time-consuming issues, would potentially be done outside of the health system. So they're not spending so much time working to create those. Number 3, the policy arena. We heard a great summary from Indira. But to really think through the policy incentives for health system adoption, especially coming after the pandemic, and if what we have now has enough teeth. And lastly, thinking through broad stakeholder engagement and thinking about the critical need of UDI for real world evidence studies and how we're going to get there and support systems that already have implemented UDIs and those that have not. Last slide, please. So with that, I'm going to say thank you from Sanket and myself for your attention and your interest, and I will pass off to our next presenter, Dr. Jimmy Chang.
Thank you very much, Natalia. It is an honor and a pleasure to be a participant and a presenter here at the NESTcc rollout of our playbook. my perspective is going to be focused on health system side. And I will be talking about over the next 15 minutes, what we did at Duke, implementation of unique device identification in the Duke Cath Lab, what we've already achieved in terms of benefits to the health system, and also to take a little bit of a look at what problems remain as we move forward, trying to roll out UDI capture at the point of care in the operating rooms. Next slide. So the first thing I'd like to define for you is, what do we consider to be the clinically integrated supply chain? That is, if you wanted to put a name on what it is we're trying to accomplish at the healthcare enterprise, the healthcare system level, what would that name be? And I think that really is the clinically integrated supply chain. The next point is, why would or why should a healthcare enterprise want to do that? And then once you've decided that you do want to do that, what is it going to take to build it? And then again, I'll finish up with just a couple of slides about problems we're still trying to tackle, problems we're still trying to solve that I think will need to be resolved before we can call this, if you will, a done deal. Next slide. So where are most healthcare organizations? It isn't that we are all in the dark ages, that we don't have some degree of automation in terms of supply chain. In fact, if you look across the United States, I would say if you look across the world, most enterprises are in stage one. They actually have some degree of information technology incorporated into their supply chain processes. It is an organizational business function. You can't function without it. The real question is, how do you get from a supply chain focused orientation to one where you can actually use the UDI for multiple different purposes? So HIMSS has a clinically integrated supply outcomes model, a maturity model that lists, and I'm not going to read these for you, but lists various stages of the use of information about supply chain data through various different roles. And what we looked at when we thought about this was, well, where do we want to be? And what we decided early on was in the defining step that we wanted to get to at least stage 6, if not stage 7, with our UDI data. Next slide. So the clinically integrated supply chain basically is this collaboration across all of the domains of healthcare individuals, health individuals in the healthcare environment, from senior leadership all the way down to the techs in the cath lab or the operating room, that have a unified and a uniform focus on trying to accomplish this goal. I think there are really two key foundations. There's stakeholder alignment that's needed. It is the value of real-time high-quality data. And there also has to be a philosophy about that data. And that is that the data itself, the UDI in this particular case, has to be identified as a single source of truth for product identification. And the use of that data has to be encompassed, or it has to be used for all purposes that that data could be applied to. Next slide. So the key question for me was, why should a healthcare enterprise want it? So I'm a professor of medicine at Duke, professor of cardiology, also professor of informatics. And turns out that I've been involved with UDI for a long time. So I was the naturally elected champion for our enterprise and for UDI. And I asked myself the question, well, what's in it for us as a healthcare enterprise? And I looked at it from two different perspectives. One was to ask the question, what are the regulations? And as Indira and Sanket and Natalia have already mentioned, the end-to-end cohesive requirements for putting in place UDI still are really not there. Yes, they're being worked on. Hopefully they'll be accomplished in short order, and that will help drive it, if you will, via the stick approach. But it's really the carrots that I think at this point in time are why a healthcare enterprise should or would want to embark on this UDI journey. So there are really three dimensions that I believe are the drivers. I would like to put financial last, but I can tell you every executive meeting that I walked into, one of the first questions was, how much is it going to cost and when are we going to get our ROI? And so, yes, there actually is a financial opportunity. It's to lower expenses, it's to improve revenue recovery, and it's to reduce operational costs, which can all then be turned around into a formal ROI. The second dimension is improvements related to the data itself. You reduce and eliminate errors related to the device identification. You have available real-time data that can be used for various different purposes. And the single source of truth concept, I'll explain that a little bit more in a few moments, really is key to trying to figure out why an enterprise would want to accomplish this. And oh yeah, by the way, it does have to work operationally. Everything that we do, we are looking to improve efficiency. We're also looking to improve staff and clinician satisfaction, usability. How can we eliminate bottlenecks, for example, in the billing processes? How can we reduce complexity and burden? Next slide. Now, as we embarked on this journey, we were also quite cognizant, I've got enough gray hair to have been through many of these things, to realize that many times these big processes, especially ones that have a complex web that has to be weaved, oftentimes these changes fail at the level of organizations. Next slide. So what did we do to accomplish point of care UDI scanning at Duke? The first one is that, yes, somebody had to say, these are what our goals are. This is what our destination is. So these were the goals. We wanted to create a high reliability organization around device data, using the device data, the UDI specifically, as a single source of truth. We wanted to make sure that we were doing capture of the UDI at the point of care, at the point of use, like the grocery store, the point of sale, if you will. There had to be real-time data exchange of that data. No, it couldn't be stored in some computer and then downloaded to another one and the next day, et cetera. We really needed it to be real-time, and we needed not just for it to be real-time, but we needed all systems that needed access to information about devices to use the UDI globally. Next slide. So we decided to go out and start our journey in the cardiac cath lab. And for those of you who are in healthcare enterprises where you have not started this journey, at least not the clinically integrated supply chain, I would suggest to you that the cath lab really is an optimal environment to begin the journey. There's lots of cases, but the most important thing, and I'll get to this at the end, but the most important thing vis-a-vis point of care scanning is that all the devices and products, et cetera, supplies that we use in the cath lab are pre-packaged and they all have a barcode scan on them. That actually is something that is still a problem, especially in the OR, and I will chat about that in a few moments. Next slide. So is it as simple as buying a barcode scanner at Walmart and then plugging it into an IT system and then you're ready to go? Next slide. Well, the answer is obviously no, and being a little facetious here. The project stages that we went through, and this is reflected in the playbook, we did have a approach where we defined the steps for UDI implementation. That was the strategy setting. Then we went through a planning phase where we were specifying the data flows, the workflows, the cost, the deliverables, the timelines, et cetera. I would suggest that this is something that really needs to be considered, if you will, formal project management. The technical build, I think Natalia refers to it in the playbook as the development side. There were requirements, and I'm going to show you those in a few moments, for inventory management system, user interfaces. We had to have all of the managers of the IT systems agree to use a single source of truth and then to do end-to-end testing across those IT systems. And then we did go live, big bang. Next slide. So what does this look like? The first thing is, yes, you've heard it multiple times. I did want to just emphasize it one more time that we used UDI really as a single source of truth. It's from the manufacturer. It goes into our supply chain. It's used for our inventory management by our inventory managers. It is scanned and the usage document, including, for example, wastage, whether it was dropped on the floor, whether it was implanted in a patient, et cetera. We then take that data and put it into our clinical documentation. No, it's not the UDI, but it's the metadata that identifies the devices, et cetera, with that UDI into our procedure notes, into the EHR implant log that Indira mentioned before. We also send that same data over to charge capture and billing electronically, not on a piece of paper, and then we use it for just-in-time replenishment of inventory. Next slide. So the web starts to get a little bit more complex when you start thinking about this in terms of Okay, now where does all this data need to go from which system to which system, et cetera? And so I've represented here the major systems. There is both data to as well as data from multiple different systems, including our EHR, our procedure documentation system. Yes, we put the information into our enterprise data warehouse for clinical and research purposes. Yes, we use it for supply chain. And yeah, there actually needs to be something in the middle there that's managing all the messages so that they go to the right places, they're routed to the right places at the right time. And that's the function of the integration broker. Next slide. So what does this actually look like from a technical standpoint? This is a diagram from a manuscript. I believe it's reference number 19 in the playbook. But what you can see on the right-hand side are systems that either send or receive data. And on the left-hand side are the systems that are in the cath lab, the ones that both manage the inventory as well as the scanning console, the information that has to go in and out of the scanning system in order for the data to be useful. In the middle is our integration broker, and then all those things, abbreviations that you probably may or may not understand, but those are all HL7 V2 messages. And we can talk about the details at a later point in time, but suffice it to say, end to end, all of this had to work for the magic to really happen. Next slide. So what are our metrics? Our metrics are listed on here. We were successful in terms of our go live. Yeah, we did a lot of end-to-end testing. In fact, it was around 350, almost 400 person hours of IT time in order to make sure that when we went live, there were no glitches. This did result in real-time availability of product data. We reduced clinical documentation errors related to devices to basically zero. We saved time in our procedures. There's a placement of the UDI data into our EHR device implant table in our electronic health record. We really tightened up our inventory management and supply chain replenishment process. We have already used UDI for running our queries for device recalls. And at the present time, we continue to have about an $80,000 a year net positive, really related to lower par levels, elimination of data leakage, and reduced billing rework. Next slide. So last then concept is what else is left to do? I'd like to tell you that what we have done in the cath lab is easily transportable to the operating room. Unfortunately, that's only half true. It is true for devices that are pre-packaged, but in the operating room, there's actually a couple more problems to solve. One of them is this concept of non-steriles, things that come in on trays into the operating room. Obviously, they're sterilized before they get into the operating room, but they're supplied to the hospital in packages that then have to be broken down and repackaged into trays. So how do you scan little screws, nuts, bolts, plates, et cetera, because it's really hard to associate the UDI to these non-steriles. And then the second big problem is that the point of use in the operating room is a sterile field. The point of use in the cath lab, yes, it is at the edge of the field where you can open up a device and hand it off sterilely. But in the operating room, the point of use is actually the sterile field. Next slide. So we've actually gone through trying to figure out how to do this. And Jane Pleasance and myself and several others at Duke had a contract back in the 2014-2015 era. And we looked at ways to do this. Was it just to list things on inventory sheets, barcode scan, all these barcodes off in the inventory sheet? Was it through individual sterile packaging, which was a logistical nightmare? How about direct part marking, et cetera? The answer is we really didn't figure it out back in 2015. Next slide. So this takes me to where I think we need to go. This is a concept called set mapping, where the little plates, as you can see on there, right next to the little plate, it looks like little circles on them, are tags that identify that plate. You can do this really for any type of device that's supplied on a tray. And then the magic is to have a wand that you can then put onto the sterile field. And as you're using a device, as you pull it out of the tray, you actually tap the device. Next slide. So in conclusion, you never change things by fighting the existing reality. The existing reality is pretty bad out there, actually. To change something, build a new model that makes the existing model obsolete. So that's, I think, where we're going. Hopefully this story about the Duke experience helps you think through what it's going to take at your enterprises to bring us on board. And as I said, hopefully fairly soon we'll have approaches that will allow for point of care scanning in the operating room as well. At this point, I'd like to hand it over to my colleagues. I think Natalia and Sanket are going to help lead a panel discussion. Thank you very much for your attention.
Thank you, Jimmy. I think we'll ask, I believe the presenters or the panelists will come back on camera if they have not already. Okay. Well, first of all, I want to just start by saying and thank our presenters for really a pretty incredible presentations today, and a lot packed into a small amount of time. And really that was just an excellent update from FDA, including kind of next steps where they're going with compliance and health system education. I always learn something every time I listen to Indira, so thank you for that. Obviously, Sanket system UDI implementation, which is just critical to move forward and realize the goals set forth in the FDA rule for NESTcc and the use of real world evidence. And Jimmy just gave a great example, lots of detail. I certainly refer you to his publications and the playbook, but a health system's lived experience with implementing UDI. So I think what I'm going to do is I'm going to jump right in. I know that the audience can certainly put forth some questions as we focus on this next step area to realize the benefit and the value of UDI. But I'm going to start with a first question targeted actually at Indira. And so I guess moving forward of FDA and other federal agencies to facilitate UDI adoption, understanding that some areas are not under the purview of FDA or other agencies. And really as a second part, then what are next steps, not just FDA, but collaborative community and sort of that involvement with this. So I would love to hear from you.
Absolutely. Thank you, Natalia, for that great question. And that's sort of really where our headspace is from the UDI program perspective. As I mentioned, we've completed the infrastructure building part, the space where we have regulatory authority. From that perspective, we're definitely looking at compliance. We believe is one important area where we can make a difference to make sure that the rule requirements are implemented correctly and the data quality and good ID is reliable and usable. We feel those are important. And then making sure that we make available tools to enhance the ease of adoption, basically. That's sort of where we're focusing on as key areas. And then the other big piece is really education. Greatly appreciate the work that the ARM LUC, Learning UDI Community, has been doing. We continue to engage with them. We've reached out to American Medical Association, American Hospital Association. We want to do more outreach. I did see a question in the chat about providers not really knowing what UDI is. We have a colleague who got an implant and really didn't get an implant card, for example, with UDI on it. So we know there is a lot of work to be done in the front lines in the provider space. We've also discussed potentially reaching out to patient groups to educate them and have the patients ask for their UDI information, which is really critical. So those are some areas we are looking at from an education perspective. Now, going beyond to our sister agencies, if you will, in the federal space, closely watching the UDI inclusion in healthcare claims. And as Jimmy mentioned, there is really no end-to-end regulation, but perhaps if the requirement for UDI to be included in claim comes, we feel that would be an incentive for more hospitals to undertake capture of UDI. We're also looking to see above and beyond just the claim space, what else can we do just in terms of some of the quality metrics that CMS utilizes? Is there any way for us to work in that space to include UDI as one of those criterias? So looking for other ways to incentivize the capture of UDI really is what we're looking at in the federal space. And really setting up anything, what else can we do from an infrastructure building perspective to support adoption of UDI at this point is sort of where we are moving towards.
Andrew, I just want to ask one quick follow-up. So in terms of the collaborative community and many of those in the audience, how support the work that you're talking about and some of these relationships. I mean, obviously there are members who are in the Learning UDI community, probably members of AMA and HA. So what are your thoughts on that? How can this community get further engaged or involved with your work?
For us, it's really just listening to what's like through some of our participation in the Learning UDI community work groups, for example. It's a great forum to bring like-minded folks. It's actually super energizing to be part of those groups because not only do you understand what's working well, you also understand the gaps. It makes us sort of opens our eyes to really what's happening because we are sitting inside the FDA. Sometimes it's really hard to see, what's happening at the front lines, but we hear firsthand from the diverse stakeholder groups that, for example, the LUC brings about. And just getting ourselves out there to let people know that this is where we are moving towards has opened up new gates where people are reaching out to us. We've heard of instances where there have been barcode quality issues, which would be hard for us to find out on our own unless we had an FDA inspector going out and scanning the barcode for barcode quality, for example. So those things are helpful for us to hear, and we are being really responsive and asking people to come out and reach out to us. So being in those communities helps us understand the gaps, helps us go back and sort of consider what we're doing and what strategies are we taking, and also what are things that perhaps we need to be looking at. So that's helping us. And the more we put ourselves out there, those communities they've continued to grow, if you will. And we've gotten really positive feedback when we have gone out and reached out to people and talked about the benefits of UDI, but definitely there is tons more work to do.
Yeah, thank you. That you really highlighted the incredible importance of an interdisciplinary approach and to share perspectives because we all live in our own echo chamber, right? And so we don't necessarily know what others may be experiencing with this. So, well, thank you. I'm going to shift gears just a little bit and direct a question at Sanket that as we think about supporting real world evidence generation about medical devices, from your perspective, what next steps are needed at health systems? We have a group that have implemented UDI at the point of care. So what steps are needed for them to kind of realize this? And then we have not implemented at the point of care, even those that are very involved with medical evaluation. So I would love to hear, from your expertise, what you think are next steps for those groups.
Great point. Thanks for the question, Natalia. So I'll take the first one for health systems that have implemented UDI, although it's not common, but who have UDI available for real world evidence generation. This is obviously absolutely the first critical step. They've already taken monumental effort towards being able to generate robust real world evidence, and having been involved in some of these studies, I think we know that we can now identify the devices relatively reliably, but there's still a lot more work that needs to be done. I think there's a need to continue to develop the methods. Identifying the device, the exposure is obviously really important, but using observational methods to generate causal inference about effectiveness to study safety also requires a lot more work to be done. So I think that there's a need for, continue to build an RWE infrastructure where health systems that have the UDI available are able to contribute data, are able to understand under what parameters can observational methods and what methods can be used to answer, relevant questions to the overall medical device community. And again, at the center, so that patients are receiving safe and effective medical devices in their clinical care. And we also know that in general, at a given health system, the use of a given device might not be large enough in many cases. And so we need to have pooled data. We need to pool data from multiple health systems. And obviously in that, there can be lots of challenges around data quality and interoperability. And the idea of using distributed data networks is wonderful and huge, and has made gigantic steps forward towards being able to have larger sample sizes, patient populations. But again, more needs to be done to develop that infrastructure. Now, for health systems that haven't implemented, I think that's a little bit more of a challenge. What we've learned, in the work that we've done together is, investigators trying to generate RWE are pulling their hair out because they can't identify devices reliably without the UDI. They're having to conduct manual chart reviews. They're trying to develop natural language processing tools to identify the devices, which are obviously large lifts, take lots of resources. And so I'm hoping that the release of our playbook here, the lessons that we're learning in this session here will sort of help to propel health systems towards UDI implementation. As Jimmy said, he wishes that he didn't have finance and revenue at the top, but that's reality. Is a lot of folks are looking at that. And so we have some examples and, hopefully building momentum and helping leadership that needs to support UDI implementation as to why UDI implementation is important for the health system and how we can help to generate RWE. And I think, more on the ground, more tactical solutions, emphasizing education sharing from health systems that have implemented, helping to share their lessons learned, the challenges they've encountered, the barriers they've faced, how they've surmounted them with health systems that are considering that are earlier stages. The information technology infrastructure, again, as you discussed and as Jimmy shared, there's lots of challenges and lots of complexities that need to be ironed out. And again, I think policy, we talked about some of the sort of trying to get people engaged through carrot approach, and in some ways a stick approach may also be very helpful, in particular having policies where if the DI is required to be transmitted to claims, that's going to automatically require health systems to implement, and that's definitely going to help to propel UDI adoption in a different way. So I think there are multiple avenues that currently need to be tackled. I'm very enthusiastic. I think there's lots of great work that can be done to help support UDI implementation at health systems that haven't implemented, but there's still a lot of work to do ahead.
Thanks, Anke. I want just quick follow-up when we think about the first group. And we obviously found that less than half of our studied NESTcc Health System Network collaborators actually had implemented UDI. But when we think about that group that has UDI, is doing real world evidence studies, where is the place that to pull these folks together and to kind of advance this area? Is this something that you see coming out of NESTcc or something along the Learning UDI community model? What do you have some quick thoughts on that?
Yeah, great question. I think for RWE, I think NEST has played a central role in bringing together various health systems that have implemented UDI, and again, help to delineate when UDI has not been implemented. And I think that NEST as the center of real world evidence generation and sort of taking this charge is a perfect place. But I agree, we need to have some sort of a centralized convening body that helps to sort of bring folks together. And if that's quite the right terminology, but to sort of build momentum, because it is hard at an individual health system. Jimmy certainly can generate evidence that's really relevant among patients receiving care in the cath and EP labs and other aspects of care at Duke, but that care might be different than patients, for example, where I am in San Francisco. So we need to be able to have a way to bring lessons together, and we have a lot more to do to iron out, again, challenges in data quality, and again, generating causal inference, generating larger sample sizes for post-market safety surveillance. but again, with the UDI, it's a lot more possible than without.
Okay, great. And first of all, I want to express my sincere apologies to my long-term colleague, Mike Schiller, that at the beginning, not giving him a moment to introduce himself. So I'm sorry, Mike, if you could just tell us who you are.
No worries. You've got a packed agenda. So thank you. I really appreciate the opportunity to be here with everybody today. My name is Mike Schiller. I'm the Senior Director of Supply Chain for the AHA and for ARM. ARM is a professional membership group of the AHA, and we represent and advocate on behalf of supply chain leaders. And quickly, I know the LUC, the Learning UDI Community, has been mentioned a couple of times here. We really launched that back in earnest in 2016 as a way to bring the healthcare field together to come up with collective solutions as opposed to everybody running off and developing solutions on their own. And it's been a great way to bring all of the key stakeholder groups together in a very open environment to come up with these key solutions, key recommendations that could then be shared across the field. I think having the FDA at the table and being a participant in these learning communities, part of the work groups, has been, I think, one of the keys to success. As Indira had already indicated, they heard firsthand some of the challenges faced by the stakeholder groups, not just hospitals, but suppliers as well. So again, real privilege to be here today. Thanks, Natalia.
Right. Thanks, Mike. You know, the Learning UDI Community in the actually emulated internationally the model. So good for all of the incredibly hard work that's gone into the LUC. I'm actually going to direct a question at you, and what do you see as the role of UDI in a resilient healthcare supply chain? I think that's kind of a term. First of all, supply chain we all learned about during the pandemic if we didn't know it, and then resilience of the supply chain. So what is the role of UDI in that? And then how does it benefit a broader UDI system impacting clinical care, the value in clinical care for real world evidence studies?
Sure. Yeah, thank you. Well, as a supply chain professional, I'll put my supply chain hat on here. It really starts with the item master and the ability to incorporate the device identifier into the item master, storing that at the item packaging string level. I think that's really, really critical. That and other data standards such as the GLN will begin to give us visibility into inventory levels by location. So if you think locally within a hospital, you think within a region, you can even think nationally. I think we need to look at capturing the UDI at the POR and POU, right? So the point of receipt and the point of use, right? We've talked about point of capture quite a bit here, but again, having my supply chain hat on, we really do need to back the capture of the UDI, DI information at the loading dock, right? This allows us to understand what's coming into our organization, allows us to vet that product and eliminate, ideally, the inclusion of counterfeit products into the US healthcare supply chain. So now we know what we've received, and then we move to the point of capture, and we've talked about that quite a bit today through the various presentations, but capturing the product at that point of care gives us the ability to understand our utilization, right? Now we can go ahead and begin to decrement our inventory, what was used in the case. We can get that information from the EHR. We can send our orders to our suppliers, and in essence, begin to mirror that retail market model where you go to the cash register, you scan the product, inventory's decremented, orders are shipped, purchase orders are sent to the supplier, product is delivered to the back at the retail, in this case, back at the hospital. So we really need to do that, because once we begin to do that, we can start to move into demand planning. Right now, historically, inventory is managed through PAR levels. PAR levels is a bit of PO history or AP history data, a little bit of a tribal knowledge, some seasonal inflection that you know is going to occur. And so you bake all of that into your PAR level. But utilization and moving to a demand planning model is going to be critical to developing upstream visibility. But it really requires a number of hospitals to begin to capture at that point of use and begin to share that demand data with those suppliers before those suppliers can actually begin to do and manage their inventory more effectively and manage it upstream with their suppliers and their supply or trading partners upstream. So it really starts there and builds upstream. You know, during the height of the pandemic, hospitals were required to report the on-hand levels of PPE, what their utilization was, and what their projected days of inventory on hand were, right? Burn rate was the term that everybody used back at that point in time. That was a very, very manual process. It took, in some cases, multiple hours for hospitals to compile this information, and they were required to do that 3 times a week. So there's multiple factors that led to the manual creation or assimilation or compiling of that data. But if you've got a common DI that you're utilizing across your facility and with trading partners, that could actually accelerate the ability to understand what my utilization is. Again, if I know what I have on hand, I can then quickly calculate what my days of inventory on hand are. Last but not least, looking at the emergency use authorizations for PPE that came out back in 2020, 2021. And this could even apply to a post-pandemic environment. But if we've got global harmonization of the UDI data, we would have that ability again to understand the product from these non-traditional suppliers or gray market manufacturers. We could begin to capture some quality issues. We can certainly identify counterfeits. We all know those stories about the counterfeit masks out there, or the lack of quality or filtration quality some of these masks presented, and of course the dangers to our clinicians and patients that presented. So again, having that visibility and incorporating the UDI into those various operational and clinical aspects, I think can really bring about a strengthened, resilient supply chain. Of course, that captured that information, we've talked about it somewhat here already, gets transferred on down into the registries. If we're capturing the DI in claims, you now begin to develop and build these rich data pools where data resides that researchers can then begin to go into and start looking at outcomes. In today's value-based care environment, it really is about the patient outcomes, and we need to understand what products are going to perform best with which population that we as a hospital might be responsible for caring. I know it was a long-winded response, a lot there to unpack, but thank you.
Yeah, you know, Mike, thank you, because I think a couple of things, highlights from your answer are the incredible importance of the healthcare supply chain in order to reach safety for real evidence studies of really tackling that area most effectively. And also this very much kind of highlights the clinically integrated supply chain. They're not isolated functions here. You need a very resilient, strong supply chain in order to really tie to that clinical point of care site and beyond. So thank you for that. I'm going to turn my attention to Jimmy Chang, and just with a question, how can expertise and lessons learned be best disseminated from health systems such as Duke that have adopted UDI to health systems that haven't? And as almost part of a caveat of that, how you can also share expertise of making clinicians aware, so patients are aware of the availability of UDI. So I'd love to hear your perspectives on that.
Yeah, so thank you, Natalia. Many of these themes I think have already been discussed, but just to try to reemphasize a few of what I think is important. The starting point is that left on its own, kind of the rationale for UDI is just academic and hypothetical. So I think one of the things that we need to come together as a community about is that we need to make UDI capture and the use of that data compelling and concrete. And so to really scale This is going to take both incentives as well as tools, if you will, both carrots and sticks. So the biggest carrot, and what I do appreciate from having the opportunity to present here, is that how do we make this easier for those who have not started on this journey or who are stalled on the journey? The publication of the UDI Playbook is, I think, a great advance. The tools that are in there, it's not just instructions, but actually there are tools that you can download and use, are going to reduce the amount of intellectual effort, new effort that it takes to make the case at an individual healthcare enterprise. At the play-by-play level, there is a lot of detail. I just barely brushed on some of the, for example, IT stuff, but some of that's in the playbook. By the way, anybody who wants to just give me a call or drop me an email, because I'm happy to help you walk through some of the technology stuff. Maybe we even need to think about creating a consulting firm, a NESTcc consulting firm, or contract with somebody else to help enterprises, if you will, do the heavy lifting. And then the rest of it is that I do think that some organizations aren't going to really move until there's, if you will, this end-to-end requirements for data capture of the UDI at the point of care built into or baked into our processes of business, the transactions, the big three domains, if you will, clinical documentation, the coding and billing, and the supply chain. So this concept of the clinically integrated supply chain resonates, but we have to make it easier, both from a standpoint of not 350 hours, but hopefully just 30 or 40 hours worth of effort on the part of an enterprise, along with some degree of push, hopefully from our federal colleagues, in ways that actually makes the case.
Okay, great. Thank you. Pose a question that I would love to have the perspective from all of you. And what that is I know there's many, but if you could just choose one, what is a key gap in achieving a comprehensive UDI system and broad availability of UDIs? And what is your proposed solution for that gap? So I might just kind of start in the order I started and go back to Indira to hear her thoughts on that question.
Yeah, I think about that a lot because what is the purpose of having all this stuff if it's not being used? So definitely, great question. Not promising any, I do think that financial challenges exist for hospitals because, as Jimmy demonstrated, this is a very large undertaking, however you look at it, because all hospitals have systems of all kinds. To implement a very small system change in FDA takes us a very long time. So I can appreciate in the real world patient care world how much more complicated it would be. So definitely, funding IT system support is probably one large piece. And I do agree with Jimmy. I think the challenge is really selling the value of UDI. I do a lot of that here within CDRH. I'm always looking for value-added use cases for UDI in-house to put forward. And I think that's something that I've been toying with in how we can bring that about, whether it's through NESTcc or what can we do as demonstration projects that are simpler, easier to grasp, and really show people, yes, this is something I really want to do in my organization. I think that's what we need. And then if you bring on some of the things that are happening in the federal space, where there are certain really necessary things where UDI becomes a requirement one way or the other in different areas, I think that will definitely spur this. So really going to latch on to that, the rationale for UDI is academic and hypothetical. I so relate to that because I've experienced it, and I think that's important, finding a way to make that realistic, tangible, and not abstract. I think is huge. And then the complexity of IT implementation has to be acknowledged, and the funding necessary to do it, above and beyond everything else that's been mentioned.
Great, thank you, Indira. And And I know panelists, we're kind of in the last 5 minutes of our session. So we could just kind of spend a minute or two answering the question, but I might go to St. Cat next. What are your thoughts on a key gap and a solution?
Sure. Yeah, I think I would really be reiterating a lot of what Indira and Jimmy said. I think that definitely helping to see the benefits, helping with education. Again, I hope that the playbook helps to move the needle in that direction. And then again, I think that a stick approach, and I think realistically the one that is most likely, and I don't think that, although we might characterize it as a stick, I don't think that it's a stick. I think it'll help to improve care for Medicare beneficiaries and beyond, is a requirement in or an ultimate requirement to include the DI in claims. Research has shown that this information can be successfully transmitted. And I think ultimately this is kind of the change that we need. We're about 10 years, almost at 10 years now, past the final rule from September of 2023. And I think trying to propel it with requirement for end-to-end implementation will be huge. And if that happens, then we'll also be able to see a flourishing of a lot of the other benefits from resilient supply chain, like Mike shared with us, some of the benefits that Jimmy shared and has discussed with us, obviously from regulatory environment. And at the end of the day, it's going to help to improve patient safety. It's going to help to improve patient care. And I think that's why we're all here.
Great, thanks, Sankat. Mike, what are your thoughts? What's a key gap of achieving a comprehensive system, and what's your proposed solution for that gap?
Yeah, thank you, Natalia. I think one of the big gaps is scanning technology in the hospital setting and the ability for hospitals to allocate capital to a non-revenue generating piece of equipment. So what I would propose would be similar to the subsidies you saw previously to implement EHRs. If there could be subsidies that go to hospitals to help offset the cost that scanning technology, the acquisition of that technology, the implementation, interfacing, all of those aspects requires. Again, if you're looking at a capital budget and you're going to spend money on an MRI or you're going to spend money on scanners, MRI is going to win every day. So I think we just need to look at how do we subsidize that so that we can have that, so that that hurdle is easy for healthcare systems to clear. And we could begin to look to bring that technology in, again, to scan at the point of receipt and the point of use.
Great, thank you, Mike. And Jimmy, we're going to wrap up with your response.
Sure. So thanks. So Mike reminded me to comment about the fact that we do use scanning at the point of receipt as well as at the point of care. So Mike, in terms of our clinically integrated supply chain, yes, the UDI is embedded all the way from the loading dock to the bills that go out to account for the use of those particular devices. I do want to remind everybody, this is not a high capital expense. Duke spent less than $20,000 in cold hard cash for the devices that were required to support scanning of UDI. It really was more about IT hours, et cetera. But Natalia, to answer your question, I'm going to go in a little bit different direction. I think what needs to be done, and this is riffing on a comment that Linda Radich made, so thank you very much, is patient enablement. You know, when you get an intraocular lens implant or a hip replacement or a stent or whatever, it's a rare patient who actually knows what was put into them. Patient enablement, asking and enabling patients so that they can be a participant in healthcare is going to be a big driver. At least I believe it will be, because patients will then be demanding that information. And then the healthcare enterprises are going to say, well, how are we going to get this? Well, the easy way is to capture the UDI of the devices as they're being implanted, or turning it around as they're being explanted. That can help with surveillance and research and improve the medical product life cycle in terms of improving devices, et cetera. So I believe patient enablement is going to be really key, and we really haven't talked about that, but let's think about that and add that to the playbook as well.
Great. Well, thank you to all of you for an incredible session, fireside chat. I could spend another hour talking about issues with all of you. I do want to say to the audience that we will questions in the chat. Not all of them are addressed in the panel, and I apologize for that. So I am going to end the session and pass off to Joe Ross for a quick wrap up and call to action.
Thanks, everybody. And that was a terrific session. So I appreciate everyone's time and engagement and thinking about what is a very complicated issue. I really think one of the things that I think is important to acknowledge is that this is not the first time people have worked on this issue. People like Natalia and Jimmy, Joe Drozda, folks at FDA, particularly through the MD EpiNet initiative. This has been, going on for 15, 20 years, working towards where we are right now. And I think that we owe them a debt of gratitude. We're hopefully going to be part of the solution that gets this over the finish line, that builds what I love the way Jimmy put it, the sort of the clinically integrated supply chain. But we are going to get there because it's really important for patients. It's really important for clinical care. It's really important for the sponsors and manufacturers to be able to track their devices. And it's really important for all of us to have a better, evidence generation system to help us make better decisions for patients. So thank you. I'll hand it over to Simon, who's going to be able to give you guys, everyone who's still on, a sense of next steps and where to get more information. So thank you, everyone.
Thank you, Joe. And thank you, everyone, for participating. I won't go through everybody by name because we're almost out of time, but I really appreciate the time you took on the session today. I think the information was extremely useful. I know there were a lot of questions, which is exciting, and I know we got to a lot of them. I think some of them were the same questions from different perspectives. If there are specific questions that have not been answered directly or indirectly in the follow-up, we will look to do some follow-up on the website as we move forward and address any of those as appropriate. Don't forget that you can go to the website, NESTcc.org, and download the playbook. There's a link there to access the playbook. You can also join the collaborative community, which is also on the same website under NESTcc.org/collaborative-community. But you can link all of these from the homepage. And this is, as you know, has been a lot of work to get to this point, but it is also part of the next steps with the collaborative community, which we will be engaging the external community as we go through on that process. A recording of the webinar will be posted at some point. I'm not sure exactly when, but I'm sure it's relatively quickly. And of course, you have access to NESTcc to ask any questions or follow-ups through the website moving forward. So with that, I am going to draw to an end. Thank you, Joe, for bringing this all together. Any other comments from your side, or are we good to go?
Well, I just wanted to, again, because I forgot to in the moment, say a huge congratulations to Natalia Wilson and Sanka Druva for leading this playbook effort, just to say how much time and effort they've put into this over the past year, along with the entire NEST team. I mean, it really was a joint collaboration, and we really hope that this playbook will be a resource for the health system and manufacturing community.
Great, thank you. Okay, well, thank you, everybody. At this point, we will bring the webinar to a close. Thank you again.